And Valerie Clark on Mr. Benton's committee on Human Relations and Aging, and very proud to chair this subcommittee. And Mr. Wasatowski is my right hand, just happens to be seated on my left. So, and we can begin with our agenda. If I may begin once again with our goals of this study committee, and it's to examine the role of adult day programs, to learn how adult day services fit into the philosophy of home and community-based services, to make recommendations, and to research the value of expanding these programs. So today, I would like to welcome also our first speaker, if he's here, Mr. James Peoples. And Mr. Peoples is from the Department of Community Health. Welcome, sir.
Thank you.
Are you accompanied by Ms. Shekel, perhaps? And Ms. Shekel, thank you so much for being here also. Ms. Shekel is the Director of Communications at the Department of Community Health, and we're so delighted to have you here.
Madam Chair, members of the committee, guests, I appreciate you all giving us this opportunity to speak to you this morning. I'm going to switch this out, if I can get it to switch out. All right. So again, members of the committee, Madam Chair, and guests, thank you for inviting the Department of Community Health to come and talk with you a little bit today about transportation and some other issues around adult day health. I am James Peoples, Director of Transportation for the Georgia Department of Community Health. In that capacity, I manage our non-emergency transportation program, NET. So you'll hear me say NET a lot. And then we also have an exceptional transportation program, which I won't talk about today because it doesn't necessarily affect this constituency. So just to give you a little bit of background about NET, it is a transportation program that provides transportation for Medicaid members to their appointments, their doctor's appointments, to go for medical evaluations, to go to get prescription drugs, and to receive medical equipment. It is important to note that NET is a ride-share program, meaning that you have multiple members from different constituency groups on the vehicle at the same time. So it's a free ride-share program, and so these are the places that you are eligible to go to. And if you guys have questions, we're going to take questions at the end. I'm sure you all know about the Department of Community Health. Our program is designed, or the methodology around the design of the program is that we use a broker system, and this system is primarily in place to help us with administrative efficiencies, as well as to help us operate and manage the program effectively. Most states that operate NET programs use a broker model. So if you think about managed care organizations and you think about the movement of members into managed care for their health benefits, the same applies for transportation benefits. So it's the same model that the department uses. We actually, our current broker agreements actually end on June 30 of 2017. So we are in the process now of getting prepared for the next request for proposals, the next RFP, which would go out in the summer of next year. Some of the responsibilities of the broker include gatekeeping, maintaining a provider network, a transportation provider network, ensuring compliance with driver and vehicle requirements, trip assignments, reservations, confirmation numbers, quality assurance, administrative oversight, and reporting. So our brokers pretty much manage the day-to-day operations of the transportation program, and we at DCH oversee that day-to-day operation. We put escort and attendant services in here to let you know that specifically for this population, because this could be an issue for them, Because we are a rideshare program, there's really one seat per member, and seating is limited, of course. However, we do have a policy in place to that where if a member needs an escort or an attendant, that person can also ride. The other part to that is if a member decides to use public transportation, which we encourage, we will also pay for that member's escort or attendant to also ride public transportation. So who are our net brokers? We've got two brokers. Logisticare is one and Southeast Trans is the other. And you can see the map. We've got the state divided up into 5 regions: North Atlanta, Central, East, and Southwest. Southeast Trans has Metro Atlanta, and for us that includes Fulton, DeKalb, and Gwinnett. And then they have the North region of the state. Logisticare has the Central region, the East region, and the Southwest region. A little data for you, just to give you an idea of how our program, how many people ride with us. This is for fiscal year 15. We had over 1 million trips, over 19 million miles, and we had probably about 400,000 members that actually rode with us in the fiscal year. And you can see those numbers broken down by region. Obviously, the Atlanta region is where most of our members ride. Geographic access standards. These standards were put in place back when the old, or the original, not the old, the current contract period that we're under, which started in 2012. These mileage standards were enacted. And it's 30 miles urban, 50 miles rural. For adult day health and pharmacy, it's 15 miles urban and 30 miles rural. The purpose for the discrepancy, or for the difference, is that when the last proposals went out and a study was done about the distances and the amount of times a member may be transported or may ride, they can ride unlimited times. But adult day health members tend to go to the adult day health facility every day, and not like a person who goes to a regular doctor's appointment who may not go every day. So those mileage standards were reduced for those types of trips as well as for pharmacy trips. It is important to note, though, that if there is a medical necessity, these standards can be waived. We also implemented in 2013 a grandfather clause. And this was as a direct result of listening to the adult day health community and talking with their team of people, that some members who had been going further than the mileage standards that were enacted prior to 2012 still needed to go to those facilities that may have been beyond the mileage standards. So we tried to write policy and put in place a grandfather clause, which means that anyone who was going to whatever ADH prior to 2012, if it was beyond the 15 miles or the 30 miles rural, that they could continue to go. We also met with the adult day health community, and they were concerned about our letter of medical necessity process. And I want to just spend about 60 seconds just telling you about this process. This process is in place for DCH and our brokers to make sure that when members need to go beyond the mileage standards, that there is a medical reason. Or in some cases, there could be a language barrier that might prevent a member from, or that might prohibit a member from going to a facility that's closer. So DCH devised this letter of medical necessity. Well, when the form first came out, a lot of community and constituency groups were a little confused and had their ideas of how we could make the form better. We met with the adult day health community. They gave us some valuable feedback, and we changed the form to incorporate that feedback. It is important to note that the broker does not determine medical necessity. Only a physician can do that. And DCH reserves the right to review or deny and approve any of the letter of medical necessities. So it's a individual form that helps us better track members that need to go beyond the mileage standards. Some of our challenges, in rural areas, there's a limited number of transportation providers, as you all can imagine, as with a limited number of healthcare providers in rural areas. That's not unique to just that area. Traffic, of course, vehicular issues that may come up, member education and outreach. A lot of people don't understand transportation and how it works. So we're constantly trying to do things like this, come to sessions like this and meet with community groups, meet with the public, meet with facilities like nursing homes to better educate them on how NET works and what they can do if they have issues. That's all I have. That's the short version because I know your time is valuable, so we'll take questions.
Well, let me tell you, that was very valuable. Thank you so much. It was an excellent presentation. Do we have questions from our committee members?
Wow.
Mr. Peoples,
Thank
we
you.
do not. Thank you.
Okay, thank you.
It was very well done.
Thank you. Thank you, Madam Chair.
At this time, I'd like to invite Miss Marcy Alter to present to us, and she also is with the Department of Community Health. Good morning.
Thank you. Good morning, Madam Chair, members of the committee. Thank you for inviting us here to speak to you about Adult Day Health and Medicaid oversight. I understand, for the record, I'm Marcy Alter, Assistant Chief of Medicaid for Provider and Policies for the Division of Medicaid. I do want to introduce Brian Dowd, who's hiding behind this column back here, who's our Director of Waiver Programs. I understand, Madam Chair, you had the opportunity to meet him at a meeting several weeks ago at Leading Age, Georgia. So he's my lifeline, in case you ask me questions that are too hard. I'm also a little old school, so I'm going to be managing my papers along with the PowerPoint. So my understanding was that you had some specific questions about Medicaid oversight and how we operate and administer the waiver programs, and then you had some specific questions about utilization over the last 10 years. I didn't know quite how to launch into oversight without giving a little bit of background of Medicaid, so I just want to hit the high notes. Medicaid, of course, is administered jointly through federal dollars as well as state funds. It's authorized through the Social Security Act, Title 19. That section of the Act we often refer to as the Medicaid Act. And within broad guidelines, each state has the authority to establish its groups of eligibility, the types and ranges of services that we provide, what the payment levels, rates of reimbursement are for those services, as well as how we administer and operate those services. Our role and responsibility is shared with the Centers for Medicare and Medicaid Services, the federal agency that oversees Medicaid programs. Federal regulations require that there be a single state agency that has oversight over the Medicaid program, and in Georgia, the Department of Community Health has been named that state agency. Our administrative duties include very high level, monitoring the quality of services, ensuring appropriate spending according to the regulations, collecting and reporting information that's necessary for effective program administration and accountability, and of course being responsive to grievances and complaints by both our providers as well as our members. This is just a depiction of the Medicaid structure. CMS operates through regional offices. There's one actually a few blocks away here in Atlanta that covers the southeast region of the country. We have a very close operating relationship with them. And I would say that we probably speak to somebody in the regional office almost daily about our operations, our activities, plans for state amendments, changes to reimbursement rates, what have you. but we are accountable to them, and regardless of any program that we oversee, they come to us for the answers. In terms of Medicaid home and community-based services, DCH has the option to administer and operate any program that we provide reimbursement for, or we can delegate those operations. For the CCSP program, Community Care Services Program, DCH has delegated the day-to-day management of operations to the Department of Human Services, specifically the Division of Aging Services. We administer and operate the SOURCE program, and together the CCSP and the SOURCE program make up the two programs that are operated and implemented under the elderly and disabled waiver. This is just a depiction of that organizational structure with our delegation to the Department of Human Services. While it is tangentially connected to us, we certainly operate in partnership.
Ms. Alter, I'm
Excuse me.
sorry to interrupt you. Could you tell us what SOURCE is, just to make sure everyone on this committee is up to
Sure.
snuff with?
Let me jump to that, because that's coming up. Oh, I'm sorry. No, I probably had it in not the best order. So, SOURCE is a home and community-based service program that provides personal supports and assistance with activities of daily living for people who are elderly and have functional disabilities. SOURCE stands for Service Options Utilizing Resources in the Community Environment. It was created as a best practice model for people with specifically high needs, to allow them to remain in place with dignity in their homes, but while getting care coordination through a medical coordination model, so their connection to a primary care physician that was intricately related to and involved in the plan of care for that person based on their physical needs. Jackie, is that okay? Okay. It is one of two programs under the elderly and disabled waiver. You have to meet an intermediate nursing home level of care. You have to have an unmet need for care. Related to what I was just describing about the physician has to approve the plan of care. Some additional aspects is the cost of services can't exceed the annual cost of care in a nursing home. For SSI but not CCSP, you have to be a recipient of SSI. And you cannot have a primary mental health or developmental disability diagnosis. Okay, I'm going to move back just a little bit.
And that's because those folks are served in another way, correct? They can, mental health or developmental disability would be served.
That was the understanding,
Okay.
and I think that when the waiver was created, it was to address people who were older with physical limitations. So that was the target population. And under a waiver, home and community-based service authority, you can target the population that way. So in terms of DCH oversight of those waiver responsibilities, there are waiver assurances. So actually within the waiver document, which is our contract with CMS, we have assurances that level of care is determined annually to assure that each member continues to meet that nursing home level of care, that is determined by somebody who's credentialed to make that determination. There are assurances related to the service planning process to make sure that that is updated as needed when a member's conditions change, or at least annually, so on and so forth. So we have a responsibility to make sure that we report back to CMS on those assurances. We report every 18 months to CMS with financial reports that demonstrate that budget neutrality against an aggregate or average annual nursing home cost. We call those the 372 reports. We, of course, conduct regular management and planning meetings when we delegate that authority, such as with the Division of Aging Services. We ensure slots are managed under the waiver program. We actually have to name how many slots are available, how many people we plan to serve each year, and we have to stay below that threshold and manage that. Our responsibility also extends to conducting program integrity audits. Anytime that there's a change in policy, we submit waiver amendments and do that collaboratively with DAS. I see you have a question, Madam Chair. Do you? Oh, okay. Looked like it. Sorry. Of course, CMS contacts us whenever they are have questions about our operations, or they've been contacted with regard to a complaint related to access to services, et cetera. So that was our oversight of a program where we have delegated the authority of day-to-day operations. In terms of what we do for SOURCE, which we administer and operate in-house, we manage the level of care validation both for CCSP and for SOURCE. So that means that we have an external reviewer look at the documentation to validate that the person indeed meets the level of care that would otherwise require nursing facility placement. We manage the slots in the waiting list. We manage budget and the state share, meaning the 36 or so percent or 33% that we pay in for every dollar of services rendered. We manage provider enrollment and of the enhanced case management agencies which operate under SOURCE. I want to move to the utilization, unless you have any questions generally about the program information that I reviewed. Okay.
You stated that there's a number that you try to stay under. What's that number?
Is it, Brian, is it 33,000? I can't remember the specific number, but I think it's right around 33,000. So that would be for both SOURCE and for CCSP. Currently in SOURCE, we have about 16,500 people enrolled, and in CCSP, I think it's about 13 or 14,000. Dr. Bullock?
Currently about 8,600.
80. Okay.
But over the course of a year, about 13,000.
Okay. Right, it's an unduplicated count of people we touch over the course of a 12-month period. Those are the numbers that I typically...
So if a person came in past that amount, they're just not accepted? Or what happens if you're over the...
If we hit a threshold, and we have in the past, but not currently, we maintain a waiting list for services. And first come, first serve on... it's triage based on need. In this program. We do it differently in different programs. I have a hard time keeping it straight.
Okay. Thank you.
Sure. Okay. So everybody has the utilization handout. It's a lot of information since you asked for 10 years of data. I'll do the high level. It shows both SOURCE and CCSP. CCSP is at the top. And going back to fiscal year 2006, we had an unduplicated count in that fiscal year of, and I'm sorry, this is specific to adult day health utilization. So 662 members utilized adult day health services in FY26 for a little over $4.2 million in costs. In 2015, if I might jump, we were serving in CCSP 960 individuals annually in adult day health for a cost of just over $5.8 million. in the SOURCE program, which certainly has grown a lot over this last 10-year period. We began with 741 folks being served in adult day health in 2006, and in this last fiscal year, we served 2,355 members for a cost of almost $16.5 million. And of course, all the numbers are there for you to see. You had also asked for the history of rates, and thought it might be easier just to demonstrate the average of what we paid per unit of service. So those are demonstrated at the bottom line. So for CCSP, that has hovered between $51 and $53, and for SOURCE between $54 and $57. And I'm not sure why it goes backwards, but good old information system calculations for you.
Thank you so much for getting this information for us. It's very helpful, and I can see that you've used your resources very wisely also in this age of money and tight
try.
budget systems. You're pretty close to your values that you used in 2006. So it speaks so highly of you. Do we have any questions of our members? We do not. Thank you
Okay.
so much.
You're welcome.
For
Thank
this
you.
valuable data. Again, also, Ms. Alter, we really appreciate it. And Mr. Dowd, thank you so much also. I'd like to invite Ms. Ginny Helms now to the podium. And Ms. Helms is the Vice President of Chapter Services and Public Policy of our Alzheimer's Association. Thank you so much for being here today.
Thank you, Madam Chair and members of the committee, for having us here today. I'd like to share with you some of the numbers that are important to us at the Alzheimer's Association. And one of those is that here in Georgia, we estimate that there are 130,000 Georgians living with Alzheimer's disease. And we expect that number to grow to 190,000 Georgians with Alzheimer's within 10 years. And the reason that number is going to grow so dramatically is that age continues to be the #1 risk factor for Alzheimer's, and baby boomers are aging. So we're going to see more people with Alzheimer's. 70% of people with Alzheimer's are cared for in the community by family members. And we estimate that there are about 506,000 caregivers here in Georgia of persons with Alzheimer's, and that they provide 576 million hours of unpaid care at a value of $7 billion. So as you can see, families are paying a big piece of caring for people with Alzheimer's. And that's one of the reasons that the Alzheimer's Association was so interested in being involved with the Georgia Alzheimer's and Related Dementias State Plan. And we had some wonderful leadership here in Georgia. Chairman Benton was one of the Alzheimer's Task Force members. He continues to serve on the Advisory Council. Dr. Jay Bulott chaired it, and some wonderful outcomes were developed as part of this. And the real goal was to look at a few factors that we needed to deal with here in Georgia. One of them is the fact that a lot of people with Alzheimer's are not diagnosed. 1 in 7 people surveyed at the age of 60 and older said they were concerned about their memory loss but had not seen a physician. And so right now what the public is doing is telling a friend, a family member, a coworker. So one of our emphasis items is on increasing detection and getting an early diagnosis. And there are different reasons that we're looking at that, one of which is that changes in the brain early affect judgment, so these people are subject to financial exploitation, etc. But the other thing that we're trying to do is really to shore up resources for care, both now and in the future. And the reality is that adult day is one of the most important forms of care. We think at the Alzheimer's Association that we need the continuum of care. We need the adult day, we need the in-home care, we need the assisted living, and we need nursing homes. But there are a couple of realities here, one of which is Adult Day plays a couple of different important roles. One is, for the person with Alzheimer's, it gives them socialization, which really helps cognition, which helps them stay independent longer. It also helps them stay engaged to where they've had a thorough day and they sleep better at night. So that's not only affecting their quality of life, it's affecting the quality of life of that caregiver. Because one of the reasons caregivers choose placement, like in nursing homes, which we want them to have when they need it, is because they're worn out. But by getting a break at an adult day center, they can rest up and be okay to carry on a bit longer. And so here at the Alzheimer's Association, we look at the cost of Medicaid. We look at what that will do to the state. Right now, people with Alzheimer's, costs spent on them represent 10% of the Medicaid budget. That number is going to grow a whole lot. But adult day continues to be one of the most affordable forms of care. And so at the Alzheimer's Association, we really want to stress that one of our biggest concerns is shoring up adult days where they're viable, and also making sure that part of that viability is the reimbursement. If they're not reimbursed, they're going to close. Last year we saw the Weinstein Center close, and that affected a lot of people. And the Weinstein Center, or ARC, actually worked very hard to help place those folks, and we did too. But it showed us how important the viability is. And we're hearing from Area Agency on Aging directors that they're only allowed to place one new person in each region each month on home and community-based services. Now, we are really big fans of both the Department of Community Health and the Division of Aging Services. But we think this really reflects the need to recognize we need adequate funding to serve these folks. In 2014, over 400 people went straight from the waiting list for home and community-based services into nursing homes. In 2015, it's about 315. Now, at the Alzheimer's Association, another trend we're seeing is that there's a lot of emphasis on nursing homes wanting the Medicare rehab rate because it's so much higher than the Medicaid rate, like probably about 4 times higher, 3 to 4 times higher. And they're also having other struggles with people with dementia. We're working on addressing those issues, like dealing with the behaviors that get them F tags and make them scared to take people with dementia. So all of these things boil down to, for us, we really want to make sure that the Adult Day program is really recognized for the vital importance that it is in shoring it up. Now, we know the state's budget has been tight over the years, but it's looking a little bit better, and I think we really need to look at funding of the people on the waiting list, getting true measures, and looking at doing better than one person a month. And I'm hoping that you all will provide some leadership to that at the legislature this year. Thank you.
Helpful to us.
And I want to give you this copy of the 2015 Alzheimer's Disease Facts and Figures, and if you need more copies, we'll order them for you.
Thank you. Ms. Booth has a question.
Hey, my question is, when you guys are processing, I know you're not with the companies, but when you're processing that bill, you're sending it to the state and you're saying you're not getting paid within the 30 days?
No, I'm not saying that at all.
Okay.
We are not involved in the funding of that. Most of the funding comes through the Division of Aging and DCH and goes to the area agencies on aging who handle that. I'm not saying that at all. We're not directly involved. What we really do, we take the calls. We have a 1-800 number as well as local numbers, and we take calls from caregivers. And what they're telling us is that they care for their loved one at home until they get worn out, and then they look for resources like Adult Day. And when they call us, they're usually saying we're out of money. We've gone through our resources. You know, it costs about $174,000 throughout the lifetime of a person with Alzheimer's, so you can see that the families go through the money. And when they don't have the money, they look to the state for the Medicaid reimbursed programs. And that's where the waiting lists are.
Gotcha. Thank you.
Thank you so much
Thank
for your
you.
presentation. Were there any questions? I'm sorry, any more questions from our committee? Thank you, Ms. Helms, very much. And at this time, we have Ms. Dorothy Davis, and Ms. Davis is a Director of Long-Term Care.
Y'all need to move that podium a little bit. That's a tight squeeze. Anyway, good morning. I'm Dorothy Davis. I represent a local nonprofit called Visiting Nurse, and we have 3 different operations. One is home health. We provide home health for 26 counties in Georgia. We are a hospice provider where we serve about 15 counties. And then the third operation is long-term care, of which we are the contract agency for SOURCE and CCSP with the Atlanta Regional Commission. So I've been asked to really discuss sort of on the ground, what does it look like from both perspectives. Marcy's had an opportunity to sort of talk about the different administrative authorities, and you know, from our perspective at Visiting Nurse, both in CCSP and SOURCE, we are making a big difference for folks who want to stay at home. I don't know about you, but it's hard to meet someone who wants to, you know, being a nursing home unless they absolutely need it. And so this is a great option for our folks in Georgia. Part of the difference that I see that sort of we've been talking about includes the waiting list. And I want to say that's a little different from our perspective between SOURCE and CCSP. And I think that has to do with the administrative authority difference. And I think y'all heard from Dr. J. Bulott last time.
Yes.
So for us in CCSP, we are getting 1 referral a month at this point. Our current census that we're serving at Visiting Nurse today is about 3,100 clients in a 10-county region. So we are the contractor for the local AAA, the Area Agency on Aging, Atlanta Regional Commission, and their sort of footprint is the 10-county area. So those members and clients represent those 10 counties. And what we're seeing is we are getting 1 member or 1 client in CCSP a month, and we're getting, well, I guess Brian does the release, about 10 a week or 10 every 15 days. So there is a difference in terms of referral patterns between the 2 programs. And I think that's an important sort of understanding that the committee understands, because I think there's a lot of confusion that occurs from a consumer perspective about how do you access services. And I think that, you know, is part of what, from the ground perspective, we are, you know, dealing with from, you know, how do we educate our folks in this region where we have, as an organization, very strong preferred partners with hospital systems, to include Grady, our safety net hospital. There's just general confusion around how to access services, where the opportunities for care are, and why would you not be able to get into care through CCSP, but you could in SOURCE. That's a real place of confusion. I think from an adult day health perspective, it is a very critical part of our service delivery and our service plan. I agree with, you know, the comments from Jenny about Alzheimer's, and really where are folks receiving care who have any kind of Alzheimer's related diseases. And there really isn't a lot of options for folks in the healthcare system to have those unmet needs and those activities of daily living that are often declining slowly over time, unless it's a, you know, something significant like a stroke, where that's a sudden onset or an infection. But, you know, this really is a lot of where our folks in Georgia come for care, and they deal with long-term care needs. And as we look at cost, it certainly is the lowest cost setting if the right people are in the program, which, you know, I think has been a significant focus for the department, to ensure that the right people are getting the care and receiving the Medicaid dollars that are allocated to the services. I didn't come with numbers around how many folks we have in adult day health. I have, you know, very much been concerned about the provider network here. Weinstein closing was a very significant impact to our clients and to our staff. It doesn't really, they're the ones, we have about 100 employees who are discussing options with families in their home, and adult day health is a very important piece that we, try to educate families on, but providers are struggling. There are, ongoing concerns, particularly from our staff, about how to effectively discuss that with caregivers. And it's out of our sort of service menu, adult day health is really the area we're most concerned about. And having talked with providers, they are seeing trends that I really wasn't even aware of from a provider perspective. That certainly raises questions because the needs are there. But I know that the transportation change back in 2012 was a significant place that created a lot of confusion, and I think, to the department's credit, that was worked through, but it still is those kinds of changes really kind of trickle downstream and take a while to figure out, and so the communication is clear. So I don't think that's as much of the issue as it once was, but I would say much of our decline in enrollment in 2012, 2013 had to do with transportation changes and having not knowing how to really execute the new rules. So, I think, whatever questions that you may have, I certainly be happy to answer from kind of the ground perspective.
Are there any questions from our members?
So in your area, Dorothy, do you have plenty of providers in the Atlanta area that you serve?
Yeah, that is not a concern for us at this point. I know that's a concern for other providers in other more, rural parts of the state, but that is not a concern for us. We have the exact opposite, where we have so many providers, and coordinating care and knowing who you are coordinating care with is a big struggle.
I have another question. Also, with the changes with Source, where we changed our, really functioning, looking at the functional issues, are you seeing that more people go into adult day centers? Or there's two different levels with centers. One, that level 1, which is the lower care, and the level 2, which is more care. Are you seeing that more people are needing that level 2 care than you used to? Or are you kind of looking at that?
In preparation for this, what I hear from staff is more it's hard to engage caregivers in the value. There's a lot of education that needs to go on, particularly if someone, even with caregiver exhaustion, and that is a big part of what we track from a quality perspective, those decision points that clients and families make when they go to a nursing home. And certainly caregiver exhaustion is one of our top reasons why people opt from a home and community-based setting into a nursing home, an institutional setting. And so it doesn't really completely make sense to me, honestly, but I do think that we are not seeing an increase.
If I may ask one question, is the difference in the number of referrals related to funding, or do you think it's related to assessment of your clients?
I think it's related not to assessment. I think it is related to funding between DCH and Department of Aging. That's my understanding. I don't fully understand it beyond that there is a certain amount of money given to Department of Aging through the budgeting process, and that's driving the slots.
Understood. Thank you very much.
Thank you.
Are there any other questions from our committee members?
Yeah,
I have a question about transportation that you mentioned, and I'm wondering if perhaps Mr. Peoples could answer that question right from where you are, sir, rather than standing. I'm just wondering, we talked about the fact that there seems to be an agreement now that you have worked out the transportation. Our first meeting, we still heard some complaints. Are you aware of the complaints on transportation? And most of it has to do with the inability to be able to pick people up the way they used to, the distance. And most of those had to do with not with the metro area or the northern area. Most of those had to do with the transportation system that's in our southern section.
Yes, transportation in rural Georgia is a challenge because we don't have as many providers, transport providers, in rural Georgia as we do up here in the urban areas. It's important to note, though, as it relates to some of the mileage restrictions, we did an analysis to see exactly when members travel, how often they travel, how far they travel, what the standards should kind of be to make sure that you still balance member choice against on-time performance. In the transportation business, on-time performance is priority number one, getting members to their appointments safe and sound. The less time they spend on the vehicle, the easier that process works. And so that's why the standards are kind of in place the way they are. However, we can always look at making modifications on not necessarily the standards, but on the way we deliver the service through our policy writing process, which we do every quarter. So to answer your first question, yes, we are aware of some of the challenges that the ADH community has brought to our attention. Where there's areas where we can improve or change policy so that it better reflects their needs, we're open to trying to look at that. We just have to be careful that if we change it for one constituency group, it could adversely impact another constituency group. And because it's ride share, we have to write policy, we have to have one policy, if you will. So, but our door is open to always talk about what those challenges are and how to address them.
Well, that's excellent to hear, and it sounds as if that's true since I think in 2012 you said that there were some concerns and that you had addressed some. We still heard several concerns about our South Georgia riders, and a lot of those, and you were not able to be here at the last meeting, a lot of those had to do with the length of time on a ride and the fact that they would pass by their senior day center and not be, it just seemed as if it was a little bit difficult in the southern section.
And Madam Chair, it is in specifically rural areas because the distances are farther for where members have to be transported, and we try not to keep members on the vehicles longer than 30 to 45 minutes. Because the longer you're on the vehicle, the more, if you have medical issues, the more issues that could arise. So again, we try our best to balance member choice and taking members as far as they need to go with getting them there safe and sound and on back to their residence in a timely manner. And so that's always a challenge for us in transportation. It will always be a challenge. I mean, you're going to always have, it's just issues like, distance, long distances, traffic, just those types of challenges, but we try to incorporate all of that when we write our policy so that it fits the program.
Thank you, and I'm well aware of that. I was a high school principal and dealt in middle school also before that, dealt with bus routes, and so I certainly understand your problem, and what makes me feel more confident is the fact that you do review it, because the concerns we had possibly need to be looked at, because they said some folks were on the bus in South Georgia for a much longer period of time. So I understand that it is the provider's job to make those routes, to set those times, but it's your job to oversee it.
Correct, and we try to encourage our brokers to transport based on normal vehicle traffic patterns. So they use Google Maps as their standard of distance, how far to go. But that is a challenge, getting members where they need to go and getting them there on time. But we are open to listening and continuing to try to make modifications when we can.
Certainly sounds as if that's true. Thank you, sir, very much. And thank you very much also for your presentation. Again, very helpful. We have Miss Dawn Alford. Was she able to be here today? I don't.
I'm sorry.
Oh.
She's not here yet. She is on the way.
Okay. Well, we might invite Miss Claire Russell to join us, and Miss Russell is going to speak from the rural perspective. Thank you, Ms. Russell.
Thank you for having me. Good morning. My name's Claire Russell, and I'm a provider, so I'm actually where the rubber meets the road. And I have a lot to tell you, and I'll try to be succinct. But I'm very passionate about this. My trade is nursing. I have been in nursing management and own this business for over 20 years. I want you to know that I own Family Care, which provides personal support. We go to clients' homes, and I also have 5 adult daycare centers. These centers are small. They're in rural areas. They were placed purposely because the areas were underserved at the time. I've had adult daycare centers since 2002. The areas that we serve span from the Georgia mountains down towards down to Statesboro in the eastern part of Georgia. Gives you an idea of the area that we cover. I want to answer. I kind of want to speak back before I tell you, some of the things that you've just heard. Some of our challenges are the funding slots, and I know that there was a question about the waiting list. And just to be clear, it is a waiting list, and they try to reassess from that waiting list. But in the last 8 weeks, I've had client die on the waiting list. So you can be on that list and not be served and lose your life from that. The other thing is a little bit about transportation. That's one of our biggest troubles or challenges down in the rural areas. If you are from here, you know that many years ago, Gwinnett County was a rural area to the suburbs of Atlanta. And so, honestly, to travel or to be in a vehicle for 30 minutes to get where you needed to go was the norm. And that's how it is serving a rural area. Only it might not be 30 miles, it might be 32. But if you live 32 miles, then you can't get on that transportation. We have found that to be kind of a hard and fast thing. We've also found times when our clients don't get picked up for whatever reason. And it's very difficult, I think, with the pool of transporters in the rural areas. It's very difficult for the clients to get the kind of treatment on the vans and to have all the rules followed as they need to follow. I recently found out that we had, and it was an accident that I found out, but we had a little client that was actually on the van 6 hours a day. He was in our center 4 hours. So those are the kind of things that kind of accidentally come spilling out of a transporter's mouth at times. It isn't that he was that far away from our center, but the man would pick him up and do all of his work and then drop him off. So there are problems out there that I think that we all need to work together and realize that sometimes when the policies are hard and fast, you still end up with a lot of problems. A lot of the clients don't want to ride. They will beg us to pick them up. And so they would rather, if we can't come get them, they would rather not come. All this to say that, well, one other thing. We have 2 clients that ride 30 miles to our center. We got a referral on a 3rd client. All these are housed in the same place. Our transport wouldn't bring the 3rd client to us because there was a center closer to us. Well, 2 of them were already coming, but they wouldn't bring us the 3rd. What I want you to hear from this is that transportation can run the business of an adult daycare center in a rural area. So they can close me, or I can make decisions to try to keep my business open. And those decisions are, I have a couple of vans on the road that are not reimbursed by the state that go and pick some of our folks up. Because my choice is either to close or to take matters into my own hands. I have some clients that I pay just individuals to come get and bring there to us. So transportation is certainly an issue. It would be wonderful. I do understand that a lot of our clients are really sick, and that's a concern. And in that vein, it would be wonderful at some time if day centers had the opportunity to get their clients and to get the same kind of reimbursement that the transporters do. Because, you know, especially you talk about Alzheimer's, you know, when an Alzheimer's person sees somebody new, how frightening that is. And so with the same person every day and that person connected to the center can make a huge difference, not only in one person's life, but the family, and also in the cost of what the state of Georgia ends up spending on that person. Next thing would be, we're dealing right now, in fact, December 8th, we go to a hearing for a client of ours who's been denied services because it said that she does not meet the standards to fit into the COG for the services. We've had her for many years. She's had a CVA, and she has paralysis on her left side. So we've got some things, we've got some challenges. I've heard you ask a question about level 1 and level 2, depending on which program you're talking about. Let's just say that for both, a level 1 would be somebody who could get off the van and with a cane or a walker get themselves into the center. A level 2 would need maybe a couple of people helping them in. What we're seeing right now, rubber meets the road in adult day health, denials right and left because they're not meeting level 1s are not meeting for adult day health. That's really, if you're a level 1, then when you come up for reassessment, you are not going to meet. That's what we're seeing. What that's leading us to is, and let me let you know, we talked about reimbursement. We've not had an increase in reimbursement for adult day health in 15 years. A lot of things have changed in 15 years. But one of the things that I have seen change in the 15 years is the acuity of these people that are coming. With the changes, with the levels of care and how they're being approved and not approved, these people are really sick, y'all. And a lot of them require one-on-one. And the reimbursement and the one-on-one. Adult day health is the most cost-effective service that the state offers. It's about $9 an hour. You can't hire a private caregiver for $9 an hour. It is huge. And unfortunately, when your loved one gets so sick that that they cannot maneuver at all without this level of assistance, that's not usually the time that you want to put them in an adult day health. So there's a lot where the rubber meets the road. It depends on a pair of glasses. I've heard people speak this morning that I respect so much. But where the rubber meets the road, if you come in and you look and see what we have, you'd be disturbed a little bit. You'd see how sick folks are. They're not coming in to play bridge. They're coming in needing care. And let me tell you what our heroes are doing. I have nurses that run these daycares. They are saving lives. Had one lady, we called her affectionately Sister, and Sister was old when we got her, or when she came and began to attend our day center. And Sister attended our day center for over 10 years with Alzheimer's. She didn't communicate with us in a normal way for any of that time. Sister walked completely bent over. I have no idea how tall Sister was when she could stand, but she would carry around books and kind of turn her head to the right and left to look at you. But when Sister would sit down, she could sing with you. You could ask her how old she was, and she would say 99, 99, 99. She was 99 when she was 102. Sister's family moved. She was over the 30-minute. She died within 6 weeks of discharge from our day health. Another, I think, real important aspect of what these adult day healths do, we're a second set of eyes. I'm not so sure about the metro area. I don't have a metropolitan center, but in the rural areas, we get to see what people are wearing when they come. We get to see, have a visual, because we're a medical model, to see how they're taken care of, how their nutritional level is, whether they're hydrated, whether they're clean. We get to see and hear what's going on in that house. And we are change agents. And if there's a situation that we can't change, we bring in help. But let me tell you, I can speak to what I have. I have homes that have been changed to adult day health. They're warm, they're welcoming, they're comfortable. We serve breakfast, snack, lunch, snack. When they go home, I sleep well. Some people, we send food home with them at night, just because we have serious question whether or not they have something to eat at night. But I know, early on, I had a client come. It was her first day. She ate, and she wanted to sleep on the sofa. That's what she wanted to do, was lay down and go to sleep. And so we shut the doors, and we let her sleep. We checked on her. Everything was good. She had a good first day. She died that night. Y'all, that's why we do what we do. We care about them. In order to stay in business, what do we need? We need for clients to be able to come before they need to be brought in on a stretcher. We need for reimbursement rates to reflect. I understand the state budget, and I understand that you can't go back and make it be okay for 15 years. But what I want you to understand is one of the most wonderful things that happened to Adult Day this year is that we got licensed. I also want you to know that I spent $130,000 with the state fire marshals putting in sprinklers, only to turn around to, when my census gets down, you know, some centers may have 7 clients come a day because of issues with transportation, not meeting level of care, because they've had a CVA and they can help ambulate or help walk into the center. You know, if I'm looking at a computer and I'm reading a level of care of someone's plan, and I see, I can just read what's going on with them, I can read one thing. I don't know how many of you, if you were standing up and you were trying to overcome a challenge, would admit how much you need help with on a daily basis. You know, there's dignity here, which is why we're going to the hearing with this client has gone into appeal, been denied services. So where the rubber meets the road, things are costly, things are going up. We need more caregivers to take care of these really sick folks, and we have very few, you know, the amount of referrals we get. Now, another, just when you hear that there's one a month, realize that that one a month means, it doesn't mean that our center gets one a month or any center gets one a month. It means that in that area, one person can get whatever service they need. And it might be to a personal care home or in their home, and nobody else on that list gets any services. So one referral a month means per area for whatever they might need.
Thank you so much, Ms. Russell. Do we have questions? Chairman Benton.
Thank you. Appreciate your presentation there. How many clients do you have that come each day on average?
In the 5 centers, I have approximately 65. We don't house them, we don't warehouse them, don't want to. So 10 years ago, we would fill that up. We would probably have 17 or 18. Now in each one, when I take a look daily to see if they've had 10, I'm thrilled. Much less than that.
And each one of those centers, you have to have a nurse there.
Yes, sir.
You have to have everything the same in each center, correct?
Everything the same. The food, the bricks and mortar, the nurse, the sprinklers, the license, everything. The RN to come in to double check and see what's behind there. Yes, sir.
What is the state reimbursement right now?
I think Ms. Alter spoke. It's $53 for CCSP. Some of it depends on what the level is.
Okay,
level
so
of
it could
care.
go up to 60.
No.
There's two levels of care for in CCSP and source. Level 1 is $50.45, and then level 2 is $63.07.
Okay, and that hasn't been increased since 1998 or 99.
I believe that's
Correct.
Okay. Are there any of your expenses that haven't gone up?
No. No, sir. No, sir.
Well, can I ask,
Why I'm in
how
business?
are you doing it? I understand that there's a love. It's a calling, just like so many other occupations that don't pay much money, but it's a reward when you do them.
The truth is, there are 2 of those 5 that just meet their expenses. But it's meeting the needs of those clients. If I'm gone, if we're not there, those few people won't be there. It's also helping the community because of the people that are employed.
Mm-hmm.
I know that's not the best business decision, but I think you can pretty much tell that's not necessarily why I'm in business. I manage very carefully, very carefully. I watch everything. I'm not the biller, obviously, but I watch everything from groceries right on down. There's no fluff. So something else happens, then all bets are off because I manage so tightly.
Okay, I know you probably can't answer this question. Maybe somebody in the audience can. Was there an ask increase for the department to cover to bring it up from 63 to? There was not an ask.
Between my association and then the other associations, we understood the governor's directive. We certainly have met with both the departments and talked with them, but we understood the governor's directive of a flat budget.
Flat budget.
Both of them and discussed rate increases for not only this service but the other services, all the other services that Ms. Alter discussed.
Okay.
Yes, sir.
On that right there, would there be a match, a federal match for if we went up on the rate? Would there be a federal match for that?
Yes, sir.
Yes, ma'am.
CMS approval of the waiver amendment that would be required, yes, sir.
I'm sorry. Would you repeat that? I didn't hear all.
That's assuming CMS approved the rate increase.
Okay. So if the rate increase is improved, there would be a federal match that would be pulled down, correct?
Yes, sir.
And is that a 1-to-1 match, or is that a 1-to-2, 1-to-3, 1-to-4?
It's based on our annual FMAP percentage, which is around 33%. So we put 33 cents in, and the feds match it to 67.
Okay, so it's 1-to-3. Okay.
It's the same for all the Medicaid. It's the same as all the.
Okay.
Across the board.
Okay.
For all Medicaid reimbursed services, unless you're a special enhanced match.
All right. All right. Thank you.
But
Appreciate your dedication to
Thank you.
looking after your community and your clients there. Thank you.
Thank you, Ms. Russell. But you're saying Medicaid would have to approve that. Medicaid would have to approve our raising our rates to match.
But, Madam Chair.
Yes, Mr. Bauer.
When you increase the other things in the other parts of the budget, that also goes to CMS. This is not like a special case, right, for CMS to look at. Anytime the legislature increases the rate, is that right?
Right. It's not quite a rubber stamp, but CMS does have to approve it, and they are looking much more closely now at our reimbursement methodology under the new Home and Community-Based Services Settings Rule, which requires any change to the rates for it to, we have to give out public notice, we have to describe how the methodology was developed to prove that it's valid.
Thank you so much. Well, we are joined by Miss Dawn Alford. Welcome. We're so glad to have you. I wonder which would be easiest for you, Miss Alford. Is it the podium? Will that work? Or would it work to speak from one of these microphones?
Let's see, if we can get this mic turned around, I think we'll try this.
Okay.
See if Nick can flip that around.
Welcome.
Thank you.
With Department of Disabilities?
I am with the Georgia Council on Developmental Disabilities. Madam Chair, committee members, I want to take this opportunity to thank you for allowing me the time to address you today. My comments will be brief. My name is Dawn Alford, and I am the Public Policy Director with the Georgia Council on Developmental Disabilities. The mission of the Georgia Council on Developmental Disabilities is to bring about social and policy changes that promote opportunities for persons with developmental disabilities and their families to live, learn, work, play, and worship in Georgia communities. GCDD envisions a state in which all persons are included in all facets of community life, have choices while exercising control over their lives, and are encouraged to achieve their full potential. There are just 2 points that I want to make today. First, I would like to touch on the new CMS guidelines called the Home and Community-Based Settings Rule that went into effect on March 17th, 2014, and that was discussed in the last study committee meeting and as well has been mentioned today. We at GCDD believe that Georgia has a great opportunity to use these guidelines as an opportunity to ensure its citizens receiving these services are truly being afforded the opportunity for full engagement into all aspects of their community and have autonomy and control over their lives in these various settings to the same extent as those who do not receive these services. The HCBS settings rule applies to both residential and non-residential settings, and the purpose of these regulations is to maximize the opportunities for participants to receive services in integrated settings and realize the benefits of community living, including opportunities to seek employment and work in competitive, integrated settings. And I just want to mention I appreciate the work of Marcy Alter through the Department of Community Health. I, as part of GCDD, am on the HCBS task force that's working to bring Georgia into compliance with these regulations. This brings me to my next point. The focus of this study committee is on adult day health services, or put another way, the study of how individuals with disabilities can have a meaningful day. So this discussion would not be complete unless I mention an initiative that we are leading at the Georgia Council on Developmental Disabilities as part of the Employment First Georgia Coalition for Georgia to become an Employment First state. Employment First means that employment should be the first and preferred option for all people, regardless of their disability. Under an Employment First policy, competitive, integrated employment in the general workforce at or above minimum wage is the first and preferred option for all working age citizens with disabilities in the publicly funded system. Let me pause briefly to say we are not, this is an option, the first option for employment. So don't misunderstand me. This is not, forcing people who do not want to work. We're just saying the first and preferred option offered to people in the publicly funded system. Because we know that virtually everyone is capable of working if that is what they want to do and so long as they have the right supports. Not only would this policy change benefit those with disabilities, but also employers and the citizens of Georgia would benefit from a yet untapped workforce of dedicated, capable employees. So with that, I would just like to extend an invitation to this entire committee and everyone in the audience to attend the Study Committee on Post-Secondary Education and Employment Options for Individuals with Intellectual and Developmental Disabilities, led by Chair Lady Dempsey, if you would like to learn more or be part of this effort. The final 2 meetings of this study committee will be held next week, November 16th and 17th, here in this building in room 506. Times are yet to be determined. I want to thank you again for this opportunity to briefly address the committee, and I would now be happy to entertain any questions or concerns you may have.
Thank you so much. That's so informative and so helpful to us. Any questions of Ms. Alford? I think not. Thank you. You were so clear and helpful to us. Thank you.
Thank you.
And to wrap it up, I wonder if I could call, I wonder if I could call on Mr. Ned Morgans to give a little conclusion for about 5 minutes and just to give us a wrap-up statement. And Mr. Morgans is the president of the Georgia Adult Day Services Association. And then we have some comments from our public who have joined us today.
Thank you very much, Madam Chairwoman, for asking me to speak again. One of the, I guess this works better this way than that direction if I'm going to be back behind the podium, I suppose. Just a couple of thoughts. One, it's very heartening to see the wide range of folks in our audience, as well as the wide range of individuals who have spoken today and about Adult Day services here in the state of Georgia. I'm looking forward to diving into the details that Marcy Alter and the folks from DCH pulled together on the data. In listening to everything, I still think that there are some significant challenges that the provider community that faces. I think the question about how do providers make ends meet in light of all the, as inflation makes costs go up, is very good. In a lot of cases, it means people are taking lower salaries. We're looking for better deals. We're looking for different food options. We're looking at cutting expenses, whereas 5 years ago we may have been able to afford transportation services in the center and augment the even if we were a provider with a broker in the state, we would be able to augment the additional costs that were going there. And today, I think, in my case, we are actively getting rid of vehicles and shrinking our fleets to be able to, because we can't afford to subsidize. Essentially, we can't afford to subsidize Medicaid transportation rates on that. And then part of that is the adversarial relationship brokers have with transportation providers. In our region, if you take somebody for 10 miles for a trip, I'll get paid about $10 for that trip. One of my colleague provider organizations will get paid $15 for that. And that's simply because we are a adult day health provider. The directors of the region that I've been in, 3 or 4 of them just said we pay adult day providers less than we do other providers for that same service. So it's an interesting cost situation. I'd like to kind of emphasize that with transportation, that remains an issue that providers continue to talk about. I think one of the neat things that we've done with the Georgia Adult Day Services Association is we have expanded our reach to different areas of the state. And so I'm not sure Claire and I really knew each other 4 or 5 years ago. We've gotten to know each other fairly well recently, and I've gotten to know other providers in the southern regions. And there are issues that have come up, and that we're looking forward to talking with James Peebles, who has done a fantastic job of helping the folks in the northern regions interact with the broker in those regions. But there's still issues. You know, somebody could be 14 miles away, live 14 miles away from that center, and then they move, and all of a sudden they're 15.1 miles. Because they moved, they are no longer eligible to continue at that service, that center, and they got to find someplace else. So there are some definite challenges that take place. In terms of rate reimbursements, I hope that have a more definite recommendation for the third and final meeting. And one of the challenges that we have is that there are actually several different categories. So in additional daily rates, there are also rates for offering physical, speech, and occupational therapy, which have been woefully inadequate for years. And so I don't know of a single adult day provider that actually can provide services under those rates. Usually you have to figure out a way to get somebody with Medicare to come in and provide those services, or take somebody else, which means that you have Medicaid recipients who are just straight Medicaid beneficiaries who really aren't able to get those kinds of services because there's no way to pay for them. The other challenge on that is as Ms. Dawn Alford spoke about, is the implementation of these home and community-based settings definition. That is going to be a significant challenge for the adult day provider network. I have a feeling it's going to be a significant challenge for the residential settings in the alternative living situation provider community as well. Most of the, it wouldn't surprise me if there's just folks that can't handle those increased costs. To some extent, it's going to require the purchase of vehicles, hiring of new staff in order to meet some of the integration requirements. These cost money. It's hard, I think there's some centers that do serve younger individuals through the source and CCSP waivers, and certainly in the Comp and Now waivers, you have more of the younger populations. I just can't even begin to imagine how we would have the resources to staff trying to help somebody that was able to find a job. There aren't really a lot of folks that come to our centers that are in a position to look for employment. If you look at our centers that I run, 95% of them are going to be 60s, 70s, 80s, 90s, with significant dementia and stroke deficits that they are struggling with. I'm looking forward to working with different provider networks. I was excited to see Wendy Davis here. I had an opportunity to talk with Ms. Patricia Walker, who runs another source agency. And looking forward to thinking about ways we can do more education, help case managers understand the adult day services, how to overcome some of the challenges of transportation, and continue to work with the different folks from DCH and the Division of Aging Services to work with that. But I do also think that there are some policy recommendations that I'm looking forward to this committee hopefully will make, and we'll have that conversation so that we can start moving forward with many of those items. Thank you. Are there any questions?
Why is the rate different because you run a center versus transportation?
I don't know, really. I've been told that there's this understanding that adult day providers get an extra amount for transportation. They don't. I think they can kind of get away with it because it's only speculation and guesswork, but providers know that they have to do it in order to get somebody. And from our regions, the Medicaid broker system, the department has really crammed down on, come down hard on the brokers to get the performance better, to improve performance. But the issue of people being on the vehicles for a long period of time, extended period of times, not going anything, the circuitous routes that people are taking, they still happen, and there's still a big concern. So providers have to get into that business, and they don't have much of a choice.
And Mr. Morgans, perhaps Mr. Peoples could respond to that question also. Thank you.
Madam Chairman, the rates are set or negotiated between the broker and the transport provider. So there's no standard rate setting. So in other words, if there is a provider that is willing to provide transportation services, they meet with the broker in their region, and those two negotiate a rate.
I see.
The rate that we established is what we pay the broker, and then they pass that down to the provider based on whatever is negotiated.
I see.
So
So
it's
it
not
could be
that
different.
if he's got a provider that's getting $15 and he's getting 10, that provider negotiated that $15 rate. So that's the issue there.
Thank you so much. Thank you. And Mr.
Yeah,
Morgans?
and I would say that negotiating is a bit of a stretch of a term once you're dealing with the broker. There is a negotiation, but a lot of times it's more of a dictation of this is what we're offering. The larger the provider, the more runs you can do, the more leverage you would have with that. But it's certainly not a standardized state thing. It's a broker to provider.
I
rate.
see.
Yeah.
I see. Thank you so much. Mr. Morgans, thank you for your wrap-up. And at this time, we have some folks from our audience who would like to speak. And Miss Kathy Simpson, again from our Alzheimer's Association, the Georgia chapter. Welcome, Miss Simpson.
Madam Chairman and committee members, prior to coming to the Alzheimer's Association, I was the sole caregiver for my mom who had Alzheimer's. Mom entered an adult day program at age 78 and shortly thereafter ended up having to go to a nursing home. I wanted to keep her at home as long as possible because that was her choice as well as mine. We wanted to make sure that she was independent, could do what she had done to enjoy her time at home after her retirement. And as she progressed and needed more and more supervision, I was not able to keep her at home. I had the choice of looking at someone coming in to care for her or placing her in adult day. I did not want her to be isolated if she had to be cared for. I preferred that she was able to socialize. The opportunity of putting her in an adult day program allowed me a respite from her and the 24-hour-a-day, 7-day-a-week care for her, but it also gave her a respite from me. It gave her the opportunity to socialize and make new friends, even though she reacquainted herself with them daily. She had to reintroduce herself every day. It was okay because she enjoyed it. She didn't want to go, but she didn't want to come home. That was tremendous for me because I had to continue working in order to support the two of us. Had it not been for the adult day program, I would have had to stop work and live on her $486 a month Social Security check that she drew from my father. Adult daycare is integral, it's necessary, and for those individuals like me who were making a good salary but supported both my mom and me and her medical needs, it was a necessity. And I ask you to consider everything you can to continue that program, the support for increased rates for providers, for transportation. I also want you to recognize that those with Alzheimer's rise to a level of disability fairly early in the progression of the disease so that they can be considered disabled, and sometimes that's not recognized, and they should have the right to choose where they prefer care and not automatically be placed in a nursing home or in a residential facility. Thank you.
Ms. Simpson, we really appreciate your input. And Mr. Walter Coffey. Mr. Coffey is the director of Leading Age Georgia.
Okay, thank you. I'm president and CEO of Leading Age Georgia. We've been around 43 years, and we're a membership organization of all kinds of housing and community-based service organizations, about 160 around the state of Georgia. And our members serve over 126,000 older Georgians. And I'd say a little over 1,000 of those are in adult day programs. Also, our adult day members make up GADSA, the Georgia Adult Day Services Association. And part of that is because in my career 20 years ago, I had the opportunity to run the adult day program at the Alzheimer's Association. Also had the opportunity to close it, didn't put that on my resume. But the main reason that the board decided to close the center, even back 20 years ago, we were still having challenges, financial challenges of the Alzheimer's Association having to raise benevolent funds and get grants to pay the cost to participate in the programs. So it was a challenge, but I have to say it was some of the most meaningful moments in my career were a day in the life of an adult day program, because Plan A never worked. You were always on Plan C, D, and E. And transportation, even back 20 years ago, we had 2 vans, one good one that fell apart regularly, that picked up participants in our program in 4 counties, so in the metro area. So, you know, we were living crazy back then, and I think that that's still true today. But our adult day members, one of the things I think that we're hearing is, and I guess for the last 3 to 4 years has been a major public policy focus of Leading Age Georgia and also many other organizations here, is just simply when we know better, we have to do better. And just the idea that with adult day services, we know, and what we've really heard expressed here today, is that it's critical to the future of serving elders in our state, supporting caregivers that are burdened. I remember many times in adult day just really being aware that it's a slippery slope, that the elders that we were serving in our program already kind of had one foot in the nursing home, because families that are trying to work, get their loved ones up, either transporting them, getting them with transportation. There's many times there's confusion involved, both undiagnosed and diagnosed dementia. There's physical disabilities that have to be taken into consideration. So actually getting that individual motivated into the program, that I think we've heard, you know, really provides a lot of necessary opportunities to quality of life. So one of the things that, you know, that we are hoping to put together is that there's many pieces to this puzzle, and there's a lot of challenges with the providers, but ultimately when we put this puzzle together, we want to see an older Georgian live in a great quality of life. And so how can we do that and honor the trends of serving people through home and community-based services, and really paying attention to these issues? I also want to thank Dr. Bulott, Mr. Peoples, Mr. Dowd, and Ms. Alter for really being actively engaged in this. And I know a lot of times, you know, our government folks, you know, they're struggling with their own guidelines and the things that they're trying to do. But you know, I think from my experience over the last 3 or 4 years, especially with this transportation, Mr. Peoples has been very accessible. He's come to meet with us. We've been able to come talk to him, and you know, we're working through these issues. Obviously, transportation is not just one thing that you check off the box and it always works out great. So, you know, if we can get consistency, we've been able to have impact on the quarterly policy reviews that they do, and they've been very supportive in helping us make this possible. The whole home and community-based service transition plan, you know, all states are suffering, trying to figure it out. And the team through DCH has been very intentional and supportive of noticing that adult day folks are kind of an outlier, and they're working on trying to address those issues at a national level. And I know Dr. Bulot is engaged with Nationwide in the same way of really paying attention, federally backing into the state level of how to make sure that there's not, you know, undue even another layer of stress on adult day providers. But right now they're launching into doing surveys, and once we help, you know, get all those surveys answered, I think then there'll be opportunities to serve more. I think that's really all I want to say today. I'm probably going to just keep signing up because I figure if I say 80% of what I want to do, that'll be great. But I want to thank you for taking this on, because a lot of us in this room do a lot of things on the federal level. We work with our national organizations. We work with colleagues in other states. And people are waiting for these study results and your recommendations. One of the last studies in the U.S. was in Louisiana 6 or 8 years ago. I know Dr. Bulot was a part of that before he came to Georgia. So there really hasn't been, everybody knows that it's challenging. There's a lot of pieces to the puzzle. So, you know, the conversation that we're able to create in our state and the results and recommendations that you make, you know, are going to help more than just older Georgians. So I want to thank you for doing that. And I just want to thank my colleagues for really stepping up and speaking their truth and really looking at how we can all work together to make this happen. So thank you.
Mr. Coffey, thank you so much for your concluding comments. And again, everyone who visited with us today was so on target with our goals. Again, to examine the role and importance, to learn how services fit in the philosophy of what you just talked about, Mr. Coffey, the Home and Community-Based Services, HCBS, which is going to be a very difficult situation for our adult day services in order to have to do field trips and the other things that are necessary to fit this bill for home and community-based. We're going to make recommendations, and we're going to research expanding these programs. And every one of you have contributed to this. I've learned so much about our Department of Community Health and the great work that you do. You have been complimented by everyone who stood up to speak today. So thank you all. And again, this meeting is concluded. Our final meeting will be in December, early December. We'll agree on a date. And at that time, we will hopefully have some recommendations. Thank you so much. And again, this meeting is concluded. Thank you all.